So I'll continue other cases on oral disease. Question 34. What's the diagnosis? What you see here is palatal hematoma, basal palatal hematoma, and here are some abrasion and erosion of teeth. The diagnosis for these findings is compatible with bulimia, and here is another board question in the past on bulimia. See here the erosion and abrasion of teeth. And here, a symptomatic lesion seen some years ago. Here is a bony structure indicative of Torus palatinus. Torus palatinus. Here is another question in the past, board question on Torus palatinus. And here is another image. Don't mistake this image with the diagnosis of Torus palatinus. As you see here, there is patch and plaque infiltration on the hard palate, and here in histopathology there is spindle cells, RBC extravasation, and vascular proliferation indicative of Kaposi sarcoma. As you know that Kaposi sarcoma in the background of HIV involve commonly the head and neck region. And the next question, compare here Torus palatinus and Torus mandibulus. Both are bony structure. Torus palatinus is located on the roof of oral cavity and Torus mandibulus on the floor of oral cavity. And here, what you see here, there is a red well demarcated area in the midline of posterior dorsal tongue. The diagnosis for this figure is compatible with median rhomboid glossitis. Other name is central papillary atrophy. It is consistently associated with candidiasis. So prescribing of azole is logical in the treatment of this disease. However, it is sometimes associated with diabetes mellitus and HIV. So the test that you could request for this patient is FPS and HIV serology. And compare these figures. Here the whole tongue is associated with lacking of papilla, but here a well-demarcated area is involved in the absence of papilla. Median rhomboid glossitis, and here you see some aphthous lesion, in history recurrent lesion, and uveitis and arthritis. Both these findings are indicative of Best syndrome that you can recommend HLA-B51. And a patient with Crohn. What do you see here? Here you see pinpoint yellow pustules in a serpentine pattern within a red background, indicative of Piostomyces vegetans. But Crohn could manifest as oral lesions with granulomatosis cheilitis-like lesion, cobblestone lesion, and afta. But the most topic that is questioned in examination is Piostomyces vegetans. Here, painful gingiva. As you see here, there is punch-out interdental papilla. This finding with the history of painful gingiva is indicative of necrotizing ulcerative gingivitis. And here, this figure is also similar to necrotizing ulcerative gingivitis, but another finding you see here is the presence of erosion that is compatible with the diagnosis of desquamative gingivitis. The term desquamative gingivitis is a general term for immunobolus disease that are associated with oral lesions. These two diagnoses are very close to each other. And here, what's the diagnosis? These teeth are indicative of Hutchinson teeth as notch peck-shaped incisors as a manifestation of late congenital syphilis. Late congenital syphilis is defined as congenital syphilis after 2 years birth. And here, another manifestation of late congenital syphilis is rugodes, as linear scar at angle of mouth. So one is Hutchinson teeth and the other is rugodes. Which drug is responsible for this discoloration? The prevalent question in board examination. The test maker liked this diagnosis as Minocycline as the causative agent for this discoloration. And here, involvement of the tongue with a tumoral-like lesion. And here, on histopathology, you see abundant pink granular cytoplasm and inclusion in the cytoplasm, indicative of granular cell tumor, that the tongue is the most common site of involvement in this neural tumor. And this is another case of granular cell tumor that is a congenital form, lesion on maxilla since childhood. Another finding in histopathology of this tumor is the hyperkeratosis of the epidermis as pseudoepithelial hyperplasia. And what's the diagnosis? What do you see here? Here, a solitary, well-demarcated, irregular plaque with atrophic center, and here, column of parakeratosis, indicative of parakeratosis. Lamellar cornoid lamella is seen here, parakeratosis. And this case, a 68-year-old man with unexplained lip swelling since 4 weeks ago, and AC level is normal. That ruled out the sarcoidosis. Chest X-ray is also normal. That is ruling out sarcoidosis. What you see here is a swelling of both face and lip. And here you see some granulomas, non-caseating granuloma, indicative of the diagnosis of orofacial cheilitis granulomatosis. If this finding is limited to the lip, the diagnosis of cheilitis granulomatosis is suggested. But when the face is also involved, the diagnosis of orofacial granulomatosis is the diagnosis. And you see here two board questions on the diagnosis of cheilitis granulomatosis. If the cheilitis granulomatosis is associated with Melchior-Rosenthal syndrome, with seventh nerve palsy, the diagnosis of Melchior-Rosenthal syndrome is suggested. With regard to this image, What is the involvement of tongue? As said before, fisher tongue is a common finding of patients with Melkersson-Rosenthal syndrome. Physiotherapy for which nerve is recommended. And in this syndrome, the facial nerve or seventh nerve is involved. And here you see a board question on the diagnosis of Melkersson-Rosenthal syndrome. And here, what is the difference between this figure and the previous figure? As you see here, there is a unilateral atrophy of the tongue, indicative of morpha as Parry-Romberg. Compare these two images. Here is Melkersson-Rosenthal syndrome with seventh nerve palsy, and here is Parry-Romberg. And what you see here is a papular nodular lesion on the lip that in histopathology there is a space-like structure full of red blood cells indicative of venous lake. And here you see an ulcer here on the tongue, and here is a histopathology full of eosinophils, indicative of eosinophilic ulcer of the oral cavity or oral mucosa or tongue. Eosinophilic ulcer of tongue or oral mucosa. And here you see a strawberry tongue here, and here in history there is a good response to administration of prednisolone. These findings are indicative of Wegener. On lab tests, there is also leukocytosis. An interesting finding in the history of this patient is a C-ANCA that is negative. As you know, among ANCA, the C-ANCA is more commonly positive in patients with Wegener, but the absence of this finding could not rule out the diagnosis of Wegener, and the presence of this strawberry tongue, leukocytosis, neutrophilia, and good response to administration of prednisolone all are indicative of Wegener. And here you see another question on Wegener. Mucocutaneous lesion with sinusitis. A good clue in the history. And here you see vasculitis-like lesion of Wegener. And here you see an infiltrative plaque in oral cavity in a diffuse form, and here wart-like lesion. These findings are indicative of verrucous carcinoma. As said before, oral florid papillomatosis and verrucous carcinoma manifest as diffuse plaque-like lesions that are more commonly white color and sometimes erythematous. And compare these figures. This is the atypia here is more prominent, and you see here the pearl. This figure is indicative of SCC rather than this figure that is indicative of verrucous carcinoma. And here you see a patient with this infiltration on the tongue with positive IHC for CD13, 33, 34, 117. that is indicative of leukemia. And here you see the green discoloration that is suggestive of this diagnosis. Compare this diagnosis with the diagnosis of multiple myeloma. As said before, these are all suggestive of leukemia in oral cavity. And here the prominent vein is the tongue, caviar tongue. And here you see some findings on palms and soles and tongue. Islands are lacking papilla, and the patient is involved in chills and fever. The diagnosis is secondary syphilis. And here you see some cases of secondary syphilis. And you see here a young child presented with high fever, lymphadenopathy. As you see here, this finding as a child, high fever and lymphadenopathy, that the tongue is the appearance of a strawberry tongue, and here you see that the exclamation are indicative of Kawasaki syndrome. What is the main comorbidity in this case? So as you know, coronary artery disease, so the answer is to heart disease. And the mainstay of treatment in this patient is administration of aspirin and IVIG. As you know, all indices as these patients are involved in anemia and leukocytosis with the predominance of eosinophils, PMNs, and increase in CRP and in ESR, but the lymphocyte counts are not increased. So the correct answer is 3. And here you see another patient with fever, and here you see the sandpaper-like papular eruption. And here also you see some lines in actually linear petechia in flexural area, and the tongue is actually a white strawberry tongue that is indicative of scarlet fever. Compare the case of Kawasaki with the case of scarlet fever. Here is a red tongue and here is a whitish tongue. And you see here also another case of Kawasaki with the tongue that is indicative. You see here a case of scarlet fever. You see here the whitish strawberry tongue. The patient presented with high-grade fever, which association is more probable. As you know, purulent pharyngitis is the most consistent finding in these patients. Purulent pharyngitis almost always present. And what's the diagnosis? You see here an accumulation of color not in the papillary derma, actually in the deeply situated. The diagnosis for this finding is amalgam tattoo. The most important key feature of this figure is the deep location of this accumulation of pigmentation. And here question 59, this 39-year-old man exhibits these changes bilaterally on the tongue the patient has never been tested for HIV. As you see here, the diagnosis for this finding is oral hairy leukoplakia. Which one is correct? Testing for HIV or biopsy with stains for EBV? As you know, the hairy oral leukoplakia is almost always associated with EBV. In the background of immunosuppression, especially the HIV, but is not confined to HIV patients. So the correct answer is biopsy with stains for Epstein-Barr virus, not A as HIV testing. And here, what's the diagnosis? Cutaneous sinus of dental origin. Lesion since birth, what's the diagnosis? As you see here, there is skin scarring and erythrodontia suggesting of SEP, congenital erythropoietic porphyria. And compare these images. In this image, with the diagnosis of cutaneous sinus of dental origin, is similar to this erythrodontia. This finding is also similar to erythrodontia. And here, positive history of tooth extraction. As you see here, there is benign, there is here hyperkeratosis, hypergranulosis, and sericiform hyperplasia. The history of tooth extraction and these findings in histopathology are indicative of the diagnosis of benign alveolar ridge keratosis. And here you see a solitary nodule on lower lip since 2 months ago with a rapidly growing speed indicative of keratoacanthoma. Here is the cruciform nodule. Positive history of weight loss. What do you see here? Here you see hyperpigmented valve plaques around the lip indicative of malignant acanthosis nigricans. And here in history we have weight loss. The most underlying cause of this condition is the GI malignancy. And here is a board question with the diagnosis of malignant acanthosis nigricans that in history we have lung carcinoma. And these are two images indicative of malignant acanthosis nigricans. And here we have a positive history of weight loss. Note to this figure as you see the glossitis, and here there are some erosive erythematous patch. These findings with this finding in the history are indicative of necrolytic migratory erythema. That the cause is glauconoma. And what's the diagnosis? As you see here, there is pinpoint erythema, and here you see enlargement and eversion of lower lip. These findings are indicative of glandular cheilitis. These patients and these findings are prone to develop SCC, glandular cheilitis. And here, lesions seen some years ago, and as you see here, these crust and erosion that is recurrent is indicative of actinic cheilitis, commonly affecting the lip and eye as conjunctivitis and cheilitis. This condition worsens typically in spring, so the course of disease is worsening in spring. Like Besse syndrome, in the disease related to oral cavity, requesting for HLA is recommended. In Besse, we request HLA B51, and here we request HLA DRB1. And the mainstay of treatment for this condition is thalidomide. And here, this is chalazion clump. What's the diagnosis? As you see here, there is verrucous patches on the lip, and the histopathology also indicative of infiltration in the dermis, indicative of DLE verrucous form. As you know, in DLE the infiltration is perifollicular and prevascular, and also maybe there is follicular plugging. But this histopathology is not showing follicular hyperkeratosis. Compare these images. You see here an image indicative of an infiltrative process. In history, there is painful oral ulcer and a patient with pulmonary disease, indicative of orofacial TB. And here, a 30-year-old man with erosive lesion. You see here severe stomatitis involving the vermilion. Here in histopathology, there is intraepidermal bulla formation and findings that overlap between pemphigus vulgaris, lichen plan, and these findings in association with intracellular and along basement membrane zone linearly are indicative of paraneoplastic pemphigus. Which one is the best substrate in this case for IIF study? As you know, rat bladder is the best substrate for paraneoplastic pemphigus. And which one is less commonly considered as the cause for this condition? You know that the most common cause is non-Hodgkin lymphoma, then CLL, then Castleman, and the answer here is thymoma. What is the diagnosis? You should note that when the question maker gives you an image of stomatitis with lip involvement and an DIF image, you should not always consider paraneoplastic pemphigus. The diagnosis of paraneoplastic pemphigus is a good choice, but not always. As you see here, there is a subepidermal bulla that is more prominent in the floor of the bulla. The diagnosis for these images is actually cicatricial pemphigoid. That this form of immunobolus disease characterizes with subepidermal bulla. In all forms of cicatricial pemphigoid, the roof of the bulla is prominent, except the type anti-epiligrin or anti-laminin free 2 that the floor of the bulla is involved. I hope you enjoy this video. In the next video, I'll continue other cases.